So yes, Dr. Anagha, why don't you start your video, and again, we will discuss the two cases together.
Yes. Is my video seen, ma'am?
Yeah.
Yeah, kept the music off. So basically, this was a very unusual complication. And this has happened to me for the first time, and blink it and you miss it kind of moment. So I'll just start the video. The first part will be in a fast forward mode. So this was a routine case where we can see the pupil is well dilated, a perfect rhexis. You can see the posterior subcapsular cataract, a gentle hydro, and perfect direct chop, phacoemulsification. Each of the nuclear fragments are being emulsified, and the perfect irrigation and aspiration. You can see the nice rhexis. And now we are going on to the normal mode. This was a hydrophilic, I'm just stopping it here. This was a hydrophilic acrylic lens, a single piece. So I'm loading the lens onto the cartridge and the cartridge onto the injector. Now please watch very carefully. I'm injecting the lens. This is in a normal speed, and look what happens suddenly. And I'm totally aghast as to what went wrong. So this is now replaying in slow motion. You can see at this point of time, suddenly the entire bag is collapsed. Even slower, as I'm withdrawing the tip of the injector, suddenly there is a pull, and for God knows what reason, this has never happened earlier, and suddenly I can see that the entire bag, there is a tear, and there is an entire bag which is now crumpled underneath it. So obviously there is no other way. I just extend that same incision, and then I can see with the lens the entire bag only comes out. So I put in pilocarpine and try to constrict the pupil, and then do a vitrectomy from the side port. So this is a totally very unusual and a very aghasting complication. And putting in tricot to see whether there is any vitreous remaining, and then doing a complete vitrectomy. So fortunately, the pupil is now round and come down. And just checking whether there are any vitreous strands in the anterior chamber. Once that is done, I'm putting in viscoelastic, and now we are going ahead with making a side port on the side. And here I'm checking whether the patency of the iris claw is there or not. I've constricted the pupil because I always believe with a dilated pupil, and it is very difficult holding the lens well. First, the iris claw is kept in the chamber, anterior chamber. Hold it very well, and then from the side, with the side port, the two side ports have to be perfectly at 180 degrees so as to give a very good hold and perfect enclavement. Doing a peripheral iridectomy and then closing the wound. So once the wound is closed, I again put in a little bit of tricot and then double check that there are no vitreous strands remaining in the anterior chamber. A little bit of the tricot has gone posteriorly, but that would probably help in reducing the post-op inflammation also. So at the end of the surgery, the lens is in place, but I was totally aghast at why this occurred, and I must have seen this video back at least 100 times.
Yeah. Thank you, Naga. Very well managed. Let's take each video one by one. There are different aspects to each of them. Dr. Agarwal's case, Dr. Shrish, I would want to know, now he has done a temporal ECC. I mean, he has done a great surgery, he's done it well. But when you know that you need to remove the lens out of the bag, would you either do just a temporal scleral tunnel or maybe go and sit superiorly and do an ECC? Is one thought, is just a one thought I wanted to be discussed.
Yeah, no, I would prefer a superior tunnel over a temporal tunnel because I got used to it. Even if it is a temporal clear corneal incision, if you have to convert, we go superiorly and make a sclerocorneal tunnel there.
Yeah.
And it was very well managed complication, but you could have prevented this complication from happening. The iris clip lens actually was introduced into the antechamber with a dilated pupil. So, like he could have injected pilocarpine and made the pupil little smaller and placed the lens on the iris surface, and he could have gone from the sides, like as Dr. Annaga showed it clearly. These side ports should be 180 degrees away, and preferably 3 o'clock and 9 o'clock position if you're sitting superiorly, and that would have helped. You can place it on the surface and then catch hold of the lens at the junction of optic and haptic with the help of a stabilizing instrument, and then go behind the pupillary margin and enclave it. So that would have prevented that complication of IOL dislocation into the vitreous cavity.
Dr. Purendra Bhasin, I just wanted, of course, it's not totally exactly relevant to the case, but in a case of a very brunescent cataract, how do we avoid a possible, zonular dialysis is a possibility. Do you say it is because of the wrong manipulation, the excessive manipulation which is occurring in the bag? So your tips for that.
Thank you. And the case was definitely a challenging case, and a lot of challenges have occurred. And ultimately, I think that is the grit of the surgeon with which he managed everything single-handedly.
Yes.
He did a VR surgery also, and he has demonstrated the skills of everything. And I should appreciate, but at the same time, I would like to add, while doing the hard cataracts, and we have seen a hard brown cataract in the previous surgery, which has been shown in this symposium only. So all these tips are there for the hard cataracts, and chances of zonular dialysis are very high. So our capsular access should be large enough. Yes. That is very important. And our chamber should remain distended with the viscoat and high density viscoelastic material. Keep the pupil dilated. Maintain the dilated pupil. That is very much important. If it is reducing, then use the iris hooks or pupil expanders. Then high vacuum phaco, as Dr. Nagarwekar has also, Sandeep has also highlighted, and I would also prefer, I start with high vacuum phaco, high energy, make a small trench, bury it, create a ledge, hold it. If you are not able to hold it, you are not getting a good hold, increase the vacuum. Don't start chopping it. If you are finding that it is, Anaga has also highlighted, if it is rotating, if it is not being balanced by the vacuum, hold it first and then you chop. And horizontal chop is better in such cases. And chop it completely till you see the red reflex, and then go and extend the chop 180 degree apart on the other side, make 2 halves. Then you make multiple pieces. I make 6 or 7 pieces or 8 pieces, but more than 5 in all these hard cataracts, above 3, grade 3 cataracts. More than 5 pieces I make. Sometimes the hemispheres which we create, they are unequal. One is larger, so you make 4 pieces in that and 2 pieces in the remaining one. So this is what, and till that time you remain in the bag. You remain in the bag, and then you engulf it one by one. Maybe a small chunk, small quadrant you can remove first to create a space, so to avoid further any zonular dialysis to happen during splitting of the nucleuses or making a chop. And then you do the phacoemulsification one by one, and that is what is mandatory, and fill the chamber with viscoelastic throughout the procedure. And this will avoid any stress on the zonules and development of zonular dialysis, because you have to see that there is a very little epinucleus in all these cases. So you should keep it when you are removing the last chunk. You should decrease the vacuum, and then you remove the last chunk at the epinucleus mode.
Yes, yes. Very well, valid points discussed. Actually, Dr. O.P. Agarwal, I was truly impressed to see your video today, that you can manage the anterior segment and posterior segment with such complete versatility. As far as Hanaga's case, it's so obvious that it was a faulty cartridge, and which did the whole thing, because even the injection of the IUL was not very forceful, or how it happened. So, but again, in her case, I was thinking with her kind of skill sets, the beautiful chops which she did, she could have cut the IUL into two halves instead of enlarging the incision and taking out the IUL. But what point she can tell me is, anyway, the plan of action was to place an iris clip lens wherein you are going to increase incision. So why did she meddle around by cutting the IUL in the...
There was no point only, because there was no point in saving the bag. The bag was totally gone.
Yes.
But I am still, feeling so bad about why and how this has happened. Can anybody, any of the expert panelists,
no, the AC might have...
has it happened to anybody? Because this has never happened to me in the past, and I was feeling so bad after such a good surgery to have such a complication.
You could have... I've had one case of a small zonular dialysis, which was handled by just placing a CTR. I feel...
why this has happened in the first place? Like,
this is a faulty injector, which has released in a wrong manner. There might have been some anterior chamber shallowing also at that time, but it didn't look so on the video.
No, madam.
I think to be added, I think the zonules must be weak. Was this case of pseudo exfoliation or something?
Nothing. It was a normal case. I had done the other end around a week ago.
Dr. Subodh?
Yeah, can I add one thing to this? Yes. I'm still so junior, but I had some similar complication with me also. Yes. This kind of lenses we are just putting in the lens that we are injecting. What I saw at the end of the insertion, at the end of the, while we are injecting the lens, at the end of the, while haptic is going inside, at that time there is a sudden push inside this lens, and that is the reason for this sudden rupture of the bag. So after that, what I started doing is that while pushing the lens, I push intermittently, just give not a continuous push, but just push and then stop, then push, then stop. Doing this for the last two years, I'm putting this kind of lens, and I'm not have any complication.
I felt was maybe when I was injecting the lens, maybe I withdrew it before the entire haptic had been released. That is the only thing. But I've seen it so many times. Every time I can see that the haptic has been released, and then I'm removing the tip from the anterior chamber. But I can't imagine it can be so bad that it could have, actually ruptured the entire bag.
Anaga,
yes.
Can I make a point?
Yeah.
Yes.
Anaga, actually, these are common in C-loop hydrophilic lenses, where when the posterior haptic is being released, there's a rotation of the lens. Okay, so the rotation is jerky. I have had some cases with Bausch & Lomb lenses. If you have a double loop thing, then it is safer. But a single loop, C-loop type, when the haptic is, the trailing haptic is being released from the tip, it suddenly jerkily rotates, the lens rotates. And in the same time, you are removing your cartridge. So the chamber was shallowing, the lens rotated, and probably the drills are slightly weak. You never knew that. So that sudden torque, where the lens rotated, chamber shallowed, and journals are weak, led to a complete journal, semi-complete, you can say, journal dialysis.
No, that's a very good explanation. Thank you, Dr. Ashok.
Yeah, could be, madam.
I think the only thing I can say this.
Yes.
Who is speaking? Sorry, I didn't.
The only thing I can say, I was watching it very carefully. You didn't go wrong anywhere.
Yeah.
And it was just a spurt of the thing. It happened. Probably the God was wanting to tell you that remain grounded. You are a very good surgeon. So it is just a warning from the God that he is always there.
Yeah.
So once we start doing too many excellent surgeries, we forget that the complication do happen. So probably this is one of that act where you went nowhere wrong. And are you doing that surgery in the topical?
Yes, yes, sir. Because the patient was
if you see it very
routine
carefully, just before you put the lens, if you go back to that video again, even before you have injected, there was a slight dilusis was happening.
No, no, sir.
So
Actually,
just before that.
No, no. Actually, this was an edited video for 4 minutes. No, sir. That is why. But there was absolutely the patient is.
Then probably it's a God's act. The God's act.
I was like so guilty. I could not sleep for.
Yeah. So it is just that we are the humans, we are the surgeons, and the complications can happen to anyone. So once you start doing 100% okay surgeries, the God comes in and tells you that
I'm still there.
Go back and learn. Go back and learn.
Yeah. I must have seen this video at least 100 times.
Otherwise, it was an absolutely well performed surgery. It was perfect rexus, perfect chop and everything.
Yeah, yeah. Thank you very much. We shall now go on to our.
It could be a negative pressure inside the anterior chamber while I'm taking out the plunger out. The vacuum which has been created into the anterior chambers volumes might be a little bit loose in the periphery, and this is how the bag was taken, coming with the plunger.